Pulmonary edema. Introduction. Pulmonary edema occurs when the alveoli fill up with excess fluid seeped out of the blood vessels in the lung instead of air. This can cause problems with the exchange of gas, oxygen and carbon dioxide, resulting in breathing difficulty and poor oxygenation of blood. Sometimes, this can be referred to as water in the lungs when describing the condition to patients. Edema, in general, means swelling. This typically occurs when fluid from inside blood vessels seeps outside the blood vessel into the surrounding tissues, causing swelling. This can happen either because of too much pressure in the blood vessels or not enough proteins in the bloodstream to hold on to the fluid in the plasma, the part of the blood that does not contain any blood cells. Definition. Pulmonary edema is fluid accumulation in the tissue and air spaces of the lungs. It leads to impaired gas exchange and may cause respiratory failure. Pulmonary edema is a condition in which the lungs fill with fluid. It's also known as lung congestion, lung water, and pulmonary congestion. When pulmonary edema occurs, the body struggles to get enough oxygen and starts to have shortness of breath. Types and causes. Classically it is cardiogenic, left ventricular, but fluid may also accumulate due to damage to the lung. This damage may be direct injury or injury mediated by high pressures within the pulmonary circulation. Cardiogenic. Congestive heart failure, which is due to the heart's inability to pump the blood out of the pulmonary circulation at a sufficient rate, resulting in elevation in wedge pressure and pulmonary edema. This may be due to left ventricular failure, arrhythmias, or fluid overload, e.g., from kidney failure or intravenous therapy. Hypertensive crisis can cause pulmonary edema as the elevation in blood pressure and increased afterload on the left ventricle hinders forward flow and causes the elevation in wedge pressure and subsequent pulmonary edema. Non-cardiogenic. Negative pressure pulmonary edema, in which a significant negative pressure in the chest, such as from an inhalation against an upper airway obstruction, ruptures capillaries and floods the alveoli. The negative pressure causes a significant increase in preload, thereby increasing pulmonary blood volume. There is also a significant increase in left ventricular afterload, which causes a decreased cardiac output. The increase in pulmonary blood volume along with a decrease in cardiac output will increase the pulmonary transudative pressures. Neurogenic causes: seizures, head trauma, strangulation, electrocution. Pulmonary embolism, which increases pressure in pulmonary artery and right side of the heart. Acute lung injury may also cause pulmonary edema through injury to the vasculature and parenchyma of the lung. Acute lung injury and ARDS cover many of these causes, but they may include inhalation of hot or toxic gases, pulmonary contusion, i.e., high energy trauma, e.g. vehicle accidents, aspiration, e.g., gastric fluid, re-expansion, i.e. post-large volume thoracentesis, resolution of pneumothorax, post-decortication, reperfusion injury, i.e. post-pulmonary thromboendarterectomy or lung transplantation. Swimming-induced pulmonary edema, also known as immersion pulmonary edema. Transfusion-associated circulatory overload, TACO, occurs when multiple blood transfusions or blood products, plasma, platelets, etc., are transfused over a short period of time. Transfusion-associated acute lung injury, thoroughly, is a specific type of blood product transfusion injury that occurs when the donor's plasma contained antibodies against the recipient, such as anti-human leukocyte antigens, HLA, antibodies or anti-neutrophil antibodies. Severe infection or inflammation, which may be local or systemic. This is the classical form of ARDS. Some causes of pulmonary edema are less well characterized and arguably represent specific instances of the broader classifications above. Arteriovenous malformation, hantavirus pulmonary syndrome, high-altitude pulmonary edema, HAPE, envenomation, such as with the venom of Atrax robustus. Pathophysiology. Sign and symptoms. Acute pulmonary edema. Sudden shortness of breath, especially after activity or while lying down. Feeling like drowning or heart is dropping. Anxiety. Trouble breathing with a lot of sweating. Breathing that sounds bubbly, wheezing, or gasping. Coughing up pink, frothy spit. Skin that's cold and clammy or looks blue or gray. A rapid, uneven heartbeat, palpitations. Feeling lightheaded, dizzy, weak, or sweaty, which can signal a drop in blood pressure. Chronic pulmonary edema. Being tired. Gain weight rapidly, this may be a sign of fluid buildup and congestive heart failure. More breathing problems than usual when active. Swollen legs and feet. Trouble breathing when lying down. Wake up at night with a breathless feeling that gets better if sit up. Wheeze. Diagnostic evaluation. History taking, complete medical and surgical history, environmental history, personal history, medicine, history of trauma. Physical examination, chest auscultation, rapid breathing, bubbling sound on chest, altered level of consciousness, wheezing, frothy sputum, cyanosis, peripheral edema, assessment of sign and symptoms, jugular vein distension. Chest X-ray. A chest X-ray will likely be the first test patient have done to confirm the diagnosis of pulmonary edema and exclude other possible causes of shortness of breath. Pulse oximetry. In pulse oximetry, a sensor attached to finger or ear uses light to determine how much oxygen is in blood. ABG analysis. Patient may have blood drawn, usually from an artery in wrist, so that it can be checked for the amount of oxygen and carbon dioxide it contains, arterial blood gas concentrations. Blood test. Patient's blood may also be checked for levels of a substance called B-type natriuretic peptide, BNP. Increased levels of BNP may indicate that pulmonary edema is caused by a heart condition. Other blood tests may be done, including tests of kidney function, thyroid function and blood count, as well as tests to exclude a heart attack, biomarkers, creatinine kinase, myoglobulin, troponin, as the cause of pulmonary edema. Electrocardiogram, ECG. This non-invasive test can reveal a wide range of information about heart. During an ECG, patches attached to skin receive electrical impulses from heart. Echocardiogram. An echocardiogram is a non-invasive test that uses a wand-shaped device called a transducer to generate high-frequency sound waves that are reflected from the tissues of heart. The sound waves are then sent to a machine that uses them to compose images of heart on a monitor. Cardiac catheterization. If tests such as an ECG or echocardiography don't uncover the cause of pulmonary edema, or patient also has chest pain, doctor may suggest cardiac catheterization and coronary angiogram. Pulmonary angiogram. Pulmonary angiogram allows for direct visualization under fluoroscopy of the arterial obstruction and accurate assessment of the perfusion deficit. Management. Medical management. The initial management of pulmonary edema, irrespective of the type or cause, is supporting vital functions. Therefore, if the level of consciousness is decreased, it may be required to proceed to tracheal intubation and mechanical ventilation to prevent airway compromise. Hypoxia, abnormally low oxygen levels, may require supplementary oxygen, but if this is insufficient, then again mechanical ventilation may be required to prevent complications. Treatment of the underlying cause is the next priority. Pulmonary edema secondary to infection, for instance, would require the administration of appropriate antibiotics. Cardiogenic pulmonary edema. Acute cardiogenic pulmonary edema often responds rapidly to medical treatment. Positioning upright may relieve symptoms. A loop diuretic such as furosemide, Lasix's registered trademark symbol, is administered, often together with morphine to reduce respiratory distress. Both diuretic and morphine may have vasodilator effects, but specific vasodilators may be used, particularly intravenous glyceryl trinitrate or ISDN, provided the blood pressure is adequate. Continuous positive airway pressure and bilevel positive airway pressure, BPAP-NIP, has been demonstrated to reduce the need of mechanical ventilation in people with severe cardiogenic pulmonary edema, and may reduce mortality. It is possible for cardiogenic pulmonary edema to occur together with cardiogenic shock, in which the cardiac output is insufficient to sustain an adequate blood pressure. This can be treated with inotropic agents or by intra-aortic balloon pump, but this is regarded as temporary treatment while the underlying cause is addressed. In severe cases, people with pulmonary edema may need intensive or critical care. In other cases of pulmonary edema, patient may need treatment to help him/her breathe. A machine will deliver oxygen under pressure to help get more air into lungs. Sometimes this can be done with a mask or cannula, also called continuous positive airway pressure, CPAP. An endotracheal tube, or breathing tube may be inserted down the throat and use mechanical ventilation. Nursing management. List of nursing diagnosis. Impaired gas exchange RT to pulmonary fluid collection evidenced by cyanosis, breathing difficulty. Ineffective airway clearance RT to fluid collection in the respiratory tract as evidenced by excessive sputum production. Ineffective breathing pattern RT to pulmonary edema as evidenced by breathing difficulty. Self-care deficit RT low oxygen level in the tissues as evidenced by verbalization of powerlessness and fatigue. Activity intolerance RT low oxygen level in the tissues as evidenced by verbalization of powerlessness and fatigue. Fluid volume excess RT to cardiogenic condition, parenteral fluid administration, kidney failure as evidenced by edema of the extremities. Hush fluid volume excess. Related factors. Here are some factors that may be related to fluid volume excess. Compromised regulatory mechanisms. Decreased cardiac output, chronic or acute heart disease. Excessive fluid intake. Excessive sodium intake. Head injury. Hormonal disturbances. Liver disease. Low protein intake. Malnutrition. Renal insufficiency. Severe stress. Steroid therapy. Defining characteristics. Fluid volume excess is characterized by the following signs and symptoms. Abnormal breath sounds, crackles. Altered electrolytes. Anxiety. Azotemia. BP changes. Change in mental status. Change in respiratory pattern. Decreased HGB or HCT. Edema. Increased central venous pressure, CVP. Increased pulmonary artery diastolic pressure. Intake exceeds output. Jugular vein distension. Oliguria. Restlessness. Specific gravity changes. Shortness of breath, orthopnea dyspnea. Tachycardia. Third heart sound, S3. Goals and outcomes. The following are the common goals and expected outcomes for fluid volume excess. Patient is normovolemic as evidenced by urine output greater than or equal to 30 ml/h. Patient has balanced intake and output and stable weight. Patient maintains HR 60 to 100 beats min. Patient has clear lung sounds as manifested by absence of pulmonary crackles. Patient verbalizes awareness of causative factors and behaviors essential to correct fluid excess. Patient explains measures that can be taken to treat or prevent fluid volume excess. Patient describes symptoms that indicate the need to consult with healthcare provider. Nursing interventions for fluid volume excess. The following are the therapeutic nursing interventions for fluid volume excess. Interventions. Rationales. Instruct patient, caregiver, and family members regarding fluid restrictions, as appropriate. Information and knowledge about condition are vital to patients who will be co-managing fluids. Limit sodium intake as prescribed. Restriction of sodium aids in decreasing fluid retention. Monitor fluid intake. This enhances compliance with the regimen. Take diuretics as prescribed. Diuretics aids in the excretion of excess body fluids. Elevate edematous extremities, and handle with care. Elevation increases venous return to the heart and, in turn, decreases edema. Edematous skin is more susceptible to injury. Consider interventions related to specific etiological factors, e.g., inotropic medications for heart failure, paracentesis for liver disease. Knowledge of etiological factors gives direction for subsequent interventions. For acute cases of fluid volume excess, cooperate with the pharmacist to maximally concentrate for fluids and medications. Concentration decreases unnecessary fluids. Anticipate admission to an acute care setting for hemofiltration or ultrafiltration. These therapies are very efficient techniques to draw off extra fluid. Administer for fluids through an infusion pump, if possible. Pumps guarantee precise delivery of for fluids. Apply a heparin lock device. This device maintains 4 axis and patency but decreases fluid delivered to the patient in a 24-hour period. Place the patient in a semi-Fowler's or high Fowler's position. Raising the head of bed provides comfort in breathing. Aid with repositioning every 2 hours if the patient is not mobile. Repositioning prevents fluid accumulation in dependent areas. Educate patient and family members regarding fluid volume excess and its causes. Information is key to managing problems. Explain rationale and intended effect of the treatment program. Follow-up care will be the patient's or caregiver's responsibility. Information is necessary to make correct choices in the future. Explain the need to use anti-embolic stockings or bandages, as ordered. These aids help promote venous return and minimize fluid accumulation in the extremities. Educate patient and family members the importance of proper nutrition, hydration, and diet modification. Knowledge heightens compliance with the treatment plan. Complications: lower extremity and abdominal swelling, buildup of fluid in the membranes that surround lungs, pleural effusion, congestion and swelling of the liver. Left untreated, acute pulmonary edema can be deadly. Prevention: control blood pressure. High blood pressure, hypertension, can lead to serious conditions such as a stroke, cardiovascular disease and kidney failure. Watch blood cholesterol. Higher than normal cholesterol levels can cause fatty deposits to form in your arteries, impeding blood flow and increasing your risk of vascular disease. Don't smoke. Smoking can increase risk of cardiovascular disease. Also avoid second-hand smoke. Eat a heart-healthy diet. Eat a healthy diet that's low in salt, sugars and solid fats and rich in fruits, vegetables and whole grains. Limit salt. It's especially important to use less salt, sodium, if have heart disease or high blood pressure. Exercise regularly. Exercise is vital for a healthy heart. Regular aerobic exercise, about 30 minutes a day, helps control blood pressure and cholesterol levels and maintain a healthy weight. Maintain a healthy weight. Being even slightly overweight increases risk of cardiovascular disease. Manage stress. To reduce risk of heart problems, try to reduce stress levels. Find healthy ways to minimize or deal with stressful events in life.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.